when we're talking about the biochemistry, we just think about biochemistry or the different cycles and the related metabolism, etc. But I must tell you, as an MBBS, when you're going, uh, when you start your clinics and you start going to your department, clinical department or the patient care, so you will realize that biochemistry department is playing a very essential and eminent role toward a patient care. And in the era of this evidence-based medicine, it is uh, very important, and no patient care can be done without a biochemistry. And as for the lab investigations are concerned, so biochemistry is taking care of about more than 80% of the patient investigations related to the patient care. So I hope you can see my screen properly. So when we are talking about the minerals, so they are the essential for they are the macronutrients or the major nutrients which are essential for the normal growth and maintenance of the body, and being categorized into majorly into the three types, like the major elements or the macro elements, the micro minerals, or also the third category is the trace minerals or the trace elements. So as a part of the definition, when the requirement of certain minerals is more than 100 milligram per day, then they are known as the uh, major elements or the macro minerals. For example, the calcium, sodium, potassium, chloride, and so on. Similarly, when the requirement is less than 100 milligram per day, we call them as the microminerals. 10 to 100 is the microminerals, right? And when the requirement goes less than 10 milligram per day, then we also categorize them as the trace elements, right? For example, the fluorine, the iodine, the chromium, the copper, and so on. And as a part of a routine clinical procedure and theoretical papers, research papers, it has become evident that the deficiency of the macronutrients, it affects more than the 50% of the world population. And it is especially to the areas of the developing countries or underdeveloped countries especially. That is, resulting into the increased morbidity and mortality rates, and also the loss of the fertility. And many international organizations like WHO, USAID, etc., they are working and supporting the programs into the various countries like India as well. And these deficiencies can, lead to the permanent impairment of or the development defect can happen in case of the infants and the children. As I said, that can be classified very well into the principle of the macro elements or the micro and the trace elements. So we are going to, study this topic into the various each mineral into the different subheads, like likewise introduction, supply and its absorptions, its functions, and the disorders related to that, right? So when we are talking about the calcium, as I said, that there are many important minerals that we also, need to know as a part of the clinics and as a part of the clinicians when we are sitting into a clinic and dealing with the patients. So why we need the calcium to know, to understand, and why our body is needing the calcium, right? So calcium is present in the body in a very large amount than any other cations, almost in to the weight, right? And the total calcium amount into a body of adults, it weighs about 1 to 1.5 kg. So you can understand that how much of the calcium by weight is present in our body. And you all know, as we have also understood and read during our class schooling as well, that the body calcium is the mostly 99% is present into the skeleton, that is the bones and the teeth, and merely a 1% or less than that is present into the tissues and to the other body fluids. Sources, as again आजकल fortification का time है, so we understand so much about, the way things are coming fortified. I really, personally, I don't think that how much the fortification is necessary. But yes, natural products are always very important, and in its raw form. So cheese, milk, fruits, vegetables, egg yolk, the legumes, they are the quite rich sources of the calcium. And for the normal adults, its requirement is about 500 milligram per day, and the child needs about 1200 milligram per day in comparison to the pregnant and lactating women, where they require 1500 milligram per day. So it means to say that when during the requirement of growth and excess or the higher end metabolism, as it happens in case of the children, the growing children, not in case of adults, and also in case of a pregnant and lactating women, that we require the requirement of the calcium, the total calcium requirement increases a lot as compared, almost more than double as compared to the normal adults. And again, as a part of clinics, when you go to clinics and during internship or even before that, when you go to your clinics of ops and gynae, so you will see that how the doctors are prescribing the supplement, the calcium supplements, the iron supplements to the pregnant and lactating women. And it is very important to maintain the stores of the body and don't let them depleting out. As far as the excretion is concerned, in feces it is about 80%, and in urine it is the 20%. So in feces it is the mostly part of the excretion which takes place. Now, when we are talking about absorption, so the small intestine, that is the duodenum, it is the first place where the first second part of the duodenum, where the absorption of the calcium mostly takes place. And again, the dietary calcium, which is being taken into food, uh, it is absorbed against the concentration gradient, that is the calcium dependent ATPase. I'll show you later into the next slide. And uh, the absorption of calcium is affected by the many factors, like the diet, the pH, diet, etc. Like the which diet is having the highest amount of calcium, which diet is having the lowest amount of calcium, and how much this absorption can take place with that food. And also in case of a pH, when that acidity, that calcium salts are soluble in acid solutions, so acidity can increase the absorption, but not the basic, right? So let's have a look at this picture. If you see, as I said that from the enterocytes lumen, that calcium is going to be absorbed and going to bind with the scalmatumate, right? And the scalp binding proteins, and it is going to be absorbed against the concentration gradient with the help of the ATPase. That is, it is the energy utilizing process against which this from the enterocyte to the gut circulation, the absorption of calcium takes place against the concentration gradient, right? Now, what are the factors that can take part into the increase or decrease absorption of calcium? As I was stressing more about the food and the pH. So the amount of magnesium in the diet, as it said that the excess magnesium in diet inhibits the calcium absorption. As in the last picture, you have seen that this this as the magnesium is going to compete with the calcium for its absorption, right? And the amount of proteins in diet is also very important because it favors the absorption of calcium. Importantly, the vitamin D, you must have read, or you're going to uh, read again. I mean, you're going to be taught into next classes that vitamin D, which is a very important factor for the absorption of the calcium, and it induces the formation of carrier protein for its transfer elsewhere, and it also acts onto the various organs like kidney, where it increases the reabsorption of the calcium, and also it is acting onto the gut to increase the absorption of the calcium. Whereas the deficiency of the vitamin D can cause the rickets in adults, rickets in children, and in osteomalacia in adults, right? And also that vitamin D has been seen as inducing the formation of this carrier protein, as I said. So with the help of that carrier protein, that the calcium can cross the intestinal mucosal epithelium and can reach to the blood circulation. And similarly, the PTH, which is also helping the increased absorption, thus raising the calcium levels. How? It is involved in the conversion of the vitamin D to its active form, that is 125 dihydroxypolycalcitriol, and it also helps into the absorption from the intestine and reabsorption from the kidney. Now, at PTH, as I said, that is going to increase the formation of active form of vitamin D, or it helps in the activation of vitamin D, and also it acts directly onto the bone, and it increases the osteoclastic activity. That means uh, where the osteoclasts, that is the that they that they train and they increase the level of calcium into the blood. I just see into this picture. If you can see my cursor, I'm not sure. So with the help of sun, that UV rays, it acts on to the liver, then forming the 25 hydroxy vitamin D, acting onto the reaches to the kidney, where ultimately forming the one active form, that is 125 dihydroxy polycalciferol, that is the vitamin D. And the PTH is also going to act onto the kidney for the activation of vitamin D, and also it is acting onto the bone for helping the bone remodeling, that is the increasing of the osteoplasticity. Now, what are the factors that can cause the decrease? Earlier was the how the factors can increase the absorption of the calcium. Now I'm talking about the factors which can decrease the absorption of the calcium. Uh, First is the calcitonin. So calcitonin is the peptide hormone which is released from the thyroid gland, and its primary function is to decrease the blood calcium level, and it acts by inhibiting the mobilization of calcium from the bones. It means it is antagonist to the PTH action. If you see PTH क्या कर रहा है? It is mobilizing calcium from the bones to the blood, whereas the calcitonin is inhibiting the mobilization of calcium from the bones, right? So calcitonin will help or maintain the blood level by decreasing the calcium or decrease absorption, whereas the PTH is going to increase the absorption, and also it acts on the bone to increase the level of calcium. Now the plasma phosphate is also a factor. Uh, it is also a factor which can help by helping in the formation of this plasma phosphates, that leads to decrease of a plasma calcium, and vice versa, because again they move against each other. And decrease in plasma protein, as seen in the last slide, when the plasma protein increase, it increases the absorption of calcium. When the plasma protein decrease, it decreases the plasma protein level. Now again, this phytic acid and the oxalates, which are present into the cereals and leafy vegetables, also help into the decreased absorption of the calcium. Now this is just a picture which is showing the comparison of the mechanism of action of the vitamin D, PTH versus the calcitonin. As I said into my first slide, I mean to the earlier slides, the vitamin D and PTH help in increase absorption and increasing the calcium levels, whereas this calcitonin is going to decrease the blood calcium, and it's going to decrease the absorption of the blood calcium. Now, if you see, the main action of the vitamin D is to increase the absorption from the gut, whereas the PTH is causing the demineralization. That means it is causing the increased osteoclastic activity, that is the bone resorption. Now, the bone resorption, as I said, that it is the process by which the osteoclasts break down the tissue into the bones, and it releases the minerals. Thus, when the osteoclasts break down, then it is ultimately going to increase the calcium levels. Thus, it's going to resulting in the transfer of calcium from the bone to the blood. Right. So this is how this PTH is going to increase the demineralization and also going to increase the blood calcium levels. So calcitonin as being antagonist to the PTH action is going to oppose the demineralization process being done by the PTH. Now then more and so on, as you can see through this through the fourth slide, the bone resorption, as I said, vitamin D decreases, PTH increase, whereas calcitonin decrease the bone resorption. In case of a rickets, the vitamin D is a drug of choice. How? Because it's going to increase the absorption from the gut and the kidney, reabsorption from the kidney, absorption from the gut. But the PTH, it is contraindicated. Why? Because अगर आप rickets के केस में PTH देंगे तो क्या होगा, bones which are already weakened is going to become more weaker in that case, because PTH तो directly bone पर react करेगा, right? So this is how it's going to happen, or the metab of the blood calcium. Now the calcium blood levels normally contains the 9 to 11 milligram per 100 ml of the calcium. The 45% of which is non-diffusible form and is bound to the albumin. The diffusible form, which is the 50 to 55%, it is being further classified into the ionizable, which is the 50%. We can say the ionized calcium, which is the 50% of the total is the active form, and the non-ionizable or the calcium citrate form, it is 5%, and the isocytes, they almost contain no calcium. Again, this is just to show the redistribution of the calcium, where the 50% is the ionized free calcium or the active form of the calcium, and the 40% is being bound to the protein, and the remaining 10% is complexed with the phosphate. Now, why we need the calcium? Because it is important for the activation of enzymes, and the calmodulin, again, it is a calcium binding regulatory protein, and uh, this it helps and it leads to the the calcium binding that leads to the activation of enzymes, for example the glycogen synthase as well. Now the calcium also mediates the excitation and contraction of the muscle fiber. There will be interaction of the calcium with the troponin C, and in that case the calcium deficiency can also cause the TT, I'll show you later. And the transmission of nerve impulses, again it is helping into the nerve conduction as well, and it is also helping into the secretion of various hormones like the insulin and PTH, and it is also very important for the second messengers like cyclic AFP, and is helping into the release of hormones like or the mechanism of action like into glucagon. It is also very important when we are talking about the blood coagulation cascade, because the calcium is also known as the factor 4. If you remember the physiological cycle of the blood cascade, and calcium also stimulates the myocardium and prolongs the systole. It is also very essential for the formation of bone, and where the mostly it is stored out of total proportion of the body. Now the hypercalcemia, which is to be defined as the more than 11 milligram per deciliter, uh, can be because of the hyperparathyroidism, because it's going to the increased PTH can going to act on to the bone and it's going to increase the blood calcium levels. And now why this PTH or hyperparathyroidism taking place? Because it can be due to the parathyroid adenoma or an ectopic PTH secreting tumor. Others can be the malignancy, multiple myeloma, prolonged immobilization, and also the thyroid diuretics, which is going to conserve the calcium into the blood. The symptoms can be anorexia, nausea, vomiting, confusion, depression, And the management is again in all the clinical, mostly into the clinical cases, the important part is to you know to identify the underlying disorder or the underlying cause or the root cause analysis, and you have to treat that underlying disorder, and meanwhile you also treat the symptomatic. You have to give the symptomatic treatment to your patient. So in that case you also it has been seen to be given with furosemide, which is the diuretics, which can promote the calcium excretion, and also the steroids, helping into the lowering the level of calcium. Now the hypocalcemia, which is to be defined as less than 8.8 milligram per deciliter, it can happen with the deficiency of vitamin D and PTH. Very simple सी बात है. दो factors in level को increase absorption करने में अगर कम हो जाएंगे तो hypercalcemia हो जाएगा, like vitamin D and PTH. Or it can also because of increase of the antagonist of the PTH, that is the calcitonic. Hypoalbuminemia, plasma protein कम हो जाएगा तो absorption कम हो जाएगा. Now the respiratory alkalosis, which can cause the increased calcium binding to the albumin. Thus, though the total amount of calcium may be same, but the ionized form or the free form of the calcium or the active form of calcium is going to be decreased, thus giving the symptoms of the hypocalcemia. Now the tryptophan is the one of symptom when the calcium is lower than the 7.5 milligram per deciliter. It can happen, and generally it is seen that accidentally it happens during the surgical removal of parathyroid glands when the surgery for the goiter is taking place, or by the autoimmune disease, which is going to ultimately destroy this or causes the necrosis of the parathyroid glands. And it causes the muscle cramps. Again, जो एक्टिवेशन एक्साइटेशन है वो कम हो जाएगा तो क्या होगा, cramps, dysarthria, seizures, fracture, again fracture because of low calcium content, and the respiratory arrest as well because of the low nerve conduction. Now the management is again to treat the underlying disorder and giving the slow IV infusion of the calcium. Now this is just to bring in back to your physiological features. What is Shostak's sign? While tapping over facial nerve causes the facial contraction, as you can see in the picture. Whereas in case of torsion sign, the inflation of the BP cuff for 3 minutes, causing the carpophysial the carpophysial spasm, right? Okay, so it's been too much about the calcium because it's very important. Now coming to the phosphorus, the total body phosphorus is about the 800 gram, and the mostly 80% is presented to the skeleton, and 20% is presented to the other tissues in the body fluids, and it is the intracellular ion present in every cell of the body, and the requirement is about the 500 milligram per day, where the milk is a good source, cereals, nuts, and meat are the moderate source. Now the phosphorus is being absorbed 70%, that is the maximum from the intestine in the form of the phosphates. And phosphorus, as I said earlier, that phosphorus also, that it holds an inverse relationship with the calcium. That means increased calcium will decrease the phosphorus, or increased phosphorus may decrease the calcium. So the factors which help in the absorption of calcium will secondarily help also the absorption of phosphate. As why? Because the unabsorbed calcium inhibits the absorption of the phosphate, and the adequate intake of calcium and phosphorus is required into one particular ratio, that is about one one to two is of 1 to 2 part of calcium versus the 1 part of the phosphorus. This is a kind of a ratio which is to be maintained by the body. And the serum levels of phosphorus, uh, the serum levels of phosphorus is about 3 to 4 milligram per deciliter, which we also call as the reference range. Means when a patient comes to you with the lab investigation, so they have certain normal reference range, beyond which, less than that reference range or more than the reference range is to be considered abnormal and to be which is required to take on the proper measures. So we call it this reference range, right? So in case of the children, it is the 5 to 6 milligram per deciliter, and the fasting levels are higher. The fasting levels of phosphate are slightly higher than the postprandial state. Uh, why? Because the postprandial decrease of phosphorus has been seen because of the utilization of phosphate for the metabolism. So in that case, if you see that the fasting levels, you find phosphorus is a bit higher than the postprandial levels. Now the whole blood phosphate is about the 40 milligram per deciliter, and because this is why, because in the RBC and WBC contain a lot of phosphate as compared to the calcium, which is being contained less by the or minimally by the erythrocytes. So hemolysis should be prevented when the blood is taken for the phosphate estimation. Why? Because hemolysis होगा, cell break होगा, so that level of calcium falsely high over, right? And you won't get the right value or the testing interpretation of your patient. Now, the factors which can affect the phosphate levels, the renal function. In case of renal failure, yes, the failure of excretion in urine takes place. That means the phosphate is not going to be increased, to be treated through the urine, and thus it increases the plasma inorganic phosphate levels. In case of PTH hormone, the PTH it inhibits the renal tubular reabsorption of the phosphate. Thus, the phosphate जब reabsorption कम होगा तो क्या होगा कि phosphate excretion in urine भी phosphate excretion in urine भी कम होगा. Thus, it also decrease the plasma phosphate. The vitamin D, the plasma inorganic phosphate decreases in case of a ricket. That means the deficiency of vitamin D. That means it decreases the deficiency of vitamin D also decreases the plasma phosphate. In case of RBC, when we say the biochemically, it exists as the dipotassium hydrogen phosphate or as the potassium dihydrogen phosphate. The organic phosphates are mainly in the form of the histose, the pentose, the trisephosphates, and the ATP. Now, the important functions of this phosphate ions is that it helps in the formation of the bone and teeth. Is also important component when it is required for the formation of the high energy phosphate compounds like the ATP, GTP, creatine phosphate, etc. Um, it also helps in the synthesis of nucleoside coenzymes uh, such as the NAD and NADP. It also helps into the RNA DNA synthesis. How? If we have read the structure of DNA, so we must have gone through the phosphodiester linkages, which is required, joining the different nucleotides, thus forming the backbone of the DNA or RNA structure. The organic phosphates also, existing into the form of the phospholipids, and there are many biochemical importance are also been associated, like sphingorophospholipids and so on. The activation of enzymes is also takes place with the help of the phosphorylation. So these are the functions of the phosphate ions. Now, one more very important function that we should not forget is the phosphate buffer system. Though it plays the moderate to minor role into maintaining the buffer system of the body, but it is also that this bicarbonate buffer is also very important and also the major buffer of the body. When we're talking about the phosphate buffer, it operates into the internal fluids of cells, and as you can see, it consists of the dihydrogen phosphate ions H2PO4. Um, Dihydrogen phosphate ions has the hydrogen ion donor, uh, uh, as an hydrogen ion donor, right? And when we are talking about hydrogen phosphate ion, then they are acting as the acceptor, that is the base. So if you see through picture, where from the capillary lumen, The CO2 enters, combining with the water, forming the H2CO3 with the help of the carbonic anhydrase. It breaks down to the H plus ions plus bicarbonate, where from the tubular cells it's released into the lumen, where it combined with the monohydrogen phosphate and forming the dihydrogen phosphate, thus being released into the urine. So it also plays an important role while maintaining the narrow limits of the body pH. Now, as I said, that the inverse relationship with the calcium takes place. It happens with the phosphorus levels, and it exists. The phosphorus, that is the P plus, what we eat, exists in body as the phosphate ions, right? And uh, uh, when the calcium level increase, the phosphorus level decrease, and the vice versa. So hyperphosphatemia, that means that how the phosphate level can increase. It can be because of the excess vitamin D, because it increases the reabsorption of the increased cell lysis because it is present in the cell. So increased cell lysis can cause the false high level of the phosphate. Renal failure, uh, decreased renal failure, so it is decreased reabsorption, right? And this sorry, renal failure is decreased excretion, hypocalcemia, and a few diuretics also, which are helping in retaining the phosphate levels. Thus, management again remains the same. The root cause analysis, treat the underlying cause, and restrict the foods which are containing the high amount of the phosphorus, right? And in case of hypophosphatemia, the malnourishment, the malabsorption, and uh, the alcohol withdrawal, the use of phosphate binding antacids. Also, it's been seen that during the parental nutrition with the inadequate replacement also can decrease the phosphate levels. So again, the treatment would remain the same. That you need to treat the underlying disorder, and you have to do the symptomatic treatment. And coming to the next, that is the magnesium. So the total body magnesium is about 25 gram, and 70% of the total is presented to the skeleton and 30% in other tissues and body fluids, mostly intracellular. Requirement is about 400 milligram per day for men and 300 milligram per day for the women. Again, that is also depending on the body mass index. And sources, the rich sources like the vegetables, the legumes, meat, fish. If you see the meat is also containing the good amount of the magnesium, and out of what we eat, the 40% is going to be ingested when it is absorbed. The 40% of the ingested magnesium is going to be absorbed, and the factors affecting the absorption of magnesium will remain same as affecting the calcium absorption, because that absorption takes place together. So the serum level of the magnesium is 1.8 to 2.2 milligram per deciliter, and about 70% exists into the free state, and remaining 30% is protein bound. Now the factors which can affect the plasma magnesium levels, the renal failure, uh, it may cause a decreased excretion of the magnesium, thus increasing the magnesium, as it happens in case of the phosphorus as well, and the hyperparathyroidism, which is causing the mobilization magnesium from the bones, thus increasing the magnesium levels. Increased urinary loss or the tubular necrosis, as in case of and the various other factors like the hyperaldosteronism, the chronic liver disease, they also cause the decreased magnesium levels. Now, magnesium plays an important role as an activator of many enzymes, which are requiring the ATP, ALP, hexokinase, and phosphocryptokinase. It's also very important for the transmission of the nerve impulses, and also it is helping the insulin dependent uptake of glucose, right? and thus the glucose tolerance depending on to the magnesium levels. Uh, Coming to the next, that is the sulfur. Uh, so the proteins contain about the 1% of the sulfur by weight, and they are the various inorganic and organic compounds which contain the sulfur into the various forms. Like in case of inorganic compounds, it is the sulfate, thisulfate, and thiocyanate. Organic compounds like the amino acids, various amino acids like the cysteine, cysteine, the proteins like the keratin, hormones like the insulin, parathyroid hormones, the various vitamins. They also contain the sulfur as an important mineral and part of their metabolism. Now, the requirement of sulfur are attained by the adequate proteins in the diet, and the excretion of sulfur is mainly through the urine and the feces. Now, as far as the biochemical functions are concerned, the proteins, as I said, the protein contain about the 1% of sulfur by the weight, and it also they help in the formation of the active sulfate, that is the PAPS, that is the 3-phosphoadenosyl 5-phosphorus sulfate, which is the active form of the sulfate and being utilized for the several reactions. For example, the synthesis of the glycose aminoglycans and detoxification. Uh, the sulfur is also being seen very essential for the structural conformation and biological functions of the various proteins. Now coming to the again very important mineral that could be studied very well, that is the iron, right? And the total body iron is about 3 to 5 grams, 3 to 5, 3 to 5 grams, and the 75% of which of the total body iron is present into the blood, and the rest is being stored in the liver, bone marrow, and muscles as a part of hemocentric. And the blood contains about the 14.5 gram of hemoglobin per 100 ml of blood. And uh, as we see, we always, directly correlate the iron with the hemoglobin. So the 75% of the total iron is in hemoglobin. So you can estimate that how much hemoglobin and iron are important and being requiring for the various metabolic functions of the body. And 5% is present into the myoglobin and 50% is present into the ferritin. Now the heme containing proteins like the respiratory enzymes, the cytochrome A, B, and C, catalase, the peroxidase, further the transferrin, ferritin, and also the hemocysteine are the important proteins which are containing the iron in their structure. Now the sources, the various animal sources like liver, kidney, spleen, heart, red meat, the plant sources, for example like date, legume, vegetables, cereals, and jaggery wood, हम लोग बहुत यूज करते हैं इंडिया में भी, and milk is being considered the poor source of the iron. And the daily allowance of iron for the normal Indian adult is 20 milligram per day, whereas in case of children, it is increasing almost double. And also in case of pregnant and lactating women, that they need about the 40 milligram per day. The mechanism is that we increase metabolism in case of in case of the children, and also in case of pregnant and lactating women, that they need the increased level of or the increased requirement of the iron. Uh, Now, how the absorption of iron takes place. So, if you see, uh, I'll tell you some, one more picture about the mucosal block theory. That means how the absorption of iron is dependent on its requirements, right? So the iron is only absorbed into its inorganic form, and it is absorbed by the upper part of the duodenum. So before it enters into its process, the gut, the ferric, that is Fe3 plus, must be converted to the ferrous, that is the Fe2, before its absorption. And this conversion of the ferric to ferrous is helped by reducing substances in the food such as the cystine and the vitamin C. And iron absorption, of course, can be decreased by the phytic acid which is present into the cereals and oxalic acid which is present into the leafy vegetables. Then further in the plasma, when it entered from the gut to the blood circulation to the plasma, in plasma the ferrous further being oxidized rapidly to the ferric state. As you see, absorption into the gut requires the conversion of the ferric to ferric. That means reducing ferric to the ferrous. And in blood, it is again requiring conversion back. That means the oxidation of ferrous to the ferric. And in plasma, this ferrous to ferric is to be carried by the transferrin, and this oxidation is to be catalyzed by the ceruloplasmin, which is a copper containing protein. So here the importance of copper comes when we are talking about the oxidation process of the iron into the plasma. And this oxidation is also to be required, so it can be carried by the transferrin, right? So uh, this is just a picture, to how to show that how this plasma iron being recirculated through the bone marrow, erythrocytes, and the reticuloendothelial and the cytoplasm, uh, and how this after being its absorption from the gut, it is being stored into the spleen and liver, and also the loss of iron is takes place through the fetus during the pregnancy, during the lactation, during the menstruation, and also a part, a very small part through the skin and the GI, right? So it is very important for all of us, especially for the females, to maintain the blood iron levels. Now, as I was mentioning about the diffusive block theory. So, as I said, that iron metabolism is maintained by regulation at the level of absorption, not by excretion. That means the diffusive block theory states that uh, when iron stores in the blood are depleted, so absorption is going to enhance. When adequate quantity of iron is stored, so that means the absorption is going to decrease. So if you see, as per the definition, iron metabolism is going to be controlled at the level of absorption, not at the level of excretion. So, if there is anemia, the iron is further absorbed into the bloodstream. The more of iron is being required. And when the transferrin is saturated with iron, any iron accumulated in the nucleus cell is lost, and the cell is going to be despermated. Now, when we are talking about the excretion, so it is never excreted in urine. It is carried on to the beta globulin, and proteins are not passed through the glomeruli, right? So for the same reason, the iron is mostly to be excreted through the feces, which is about, up to even 95%, and also through the sweat 5%, and in case of menstruation, and also uh, uh, through the milk. Now this is just a picture to show that how this uptake of iron takes place, and how it is going to be um, converted into its different form. So inside the mucosal cell, as you can see from the lumen, the iron here it comes, and this a ferric iron is formed, right? And it's complexed, with the apoferritic to form the ferritin, that is the storage form of the iron. Can you see that? Right? And the ferritin is seen in intestinal mucosal. Where the is going to be stored, it is stored into the intestinal mucosal cells, the liver, spleen, and the bone marrow. Right? So, this is how the storage of this iron takes place. Now, let's have a look Have a few words about the iron deficiency anemia as well. Um, the iron deficiency anemia, again, as I said earlier, that why we are reading the nutrients or the minerals. So it is being seen that into the developing and into the underdeveloped countries, the iron deficiency anemia, even into the India, as being the very major part of population is being involved. And the nutritional deficiency of iron is found to be the most common cause of this iron deficiency anemia, right? And the various programs being run by the government, the state, the central government to to maintain the blood level or to maintain the nutrient level of the citizens, right? So the transport form of iron is called the transferrin, as the name says, trans, right? So transfer. So transport of iron, the transport of iron is to be conducted by transferrin. The transferrin is a glycoprotein, which is a beta 1 globulin form, and the one molecule of the transferrin can transport it to ferric atoms. Whereas when we are talking about the TIBC, so these are the different terminologies when we are studying the iron deficiency anemia, or we call them as uh, the iron studies, which are being required for making the diagnosis and the prognosis, right? So there are the different forms like the total iron, the transferrin, the total iron binding capacity, transferrin saturation, and so on. So transferrin मैंने आपको बताया, that is the transport form of iron, and PIBC is the how much of the iron uh, is combined with the transferrin. So indirectly it is giving you the information about the iron. या फिर how much of free transferrin is available. So PIBC in plasma is provided by the transferrin, and one third of it is saturated with iron. So let's see how the iron deficiency anemia gives the picture. अगर आयरन कम होगा तो क्या होगा, टोटल आयरन बाइंडिंग कैपेसिटी इंक्रीज रहेगी, क्यों? क्योंकि ब्लड में आयरन कम है, ठीक है, तो फ्री ट्रांसफरेंट लेवल तो इंक्रीज हो जाएगा, राइट? तो जब फ्री ट्रांसफरेंट इंक्रीज हो जाएगा तो इट मींस टोटल आयरन बाइंडिंग कैपेसिटी इंक्रीज हो गई, ठीक है, मतलब कि more of transferrin, free transferrin is available to attach with the iron, but iron तो already कम है body में, तो इसका मतलब TIBC, total iron binding capacity, is going to increase when the transferrin, free transferrin level is going to increase. But on the other side, the serum iron level is going to be reduced. So in case of iron deficiency anemia, you'll find a low total serum iron low or the reduced. TIBC and transferrin level or the transferrin saturation is going to increase. Nowadays, oral iron supplementation is very much treatment of choice, and also being given as in the form of the supplement when we are talking about the pregnant and lactating women. And on to the other side, uh, this is hemosclerosis. Okay, let me give you some more information about the iron deficiency anemia as well. बात ये हुई कि I mean how we going to identify the iron deficiency anemia होता क्या? So as I was talking to you about the developing countries, so the nutrition deficiency of iron is again is the prominent cause, as I said in the uh, first line, but also it can also happen with the lack of absorption. It can also happen with a hookworm infection, and also because of repeated pregnancy. Now why? Because the body stores on fire is going to be depleted with each pregnancy. So so the couple which are going for the repeated pregnancy, or increased number of children, that is going to badly affect the health of a woman. So which may not be a practice now these days, but maybe into some other areas, yes. So um, uh, this is the iron deficiency anemia. Now when we are talking about hemosiderosis, are simply the iron excess, iron less, iron deficiency anemia. Iron excess means hemosiderosis. So those receiving the repeated blood transfusions and will the the hemolysis or the breakdown of RBCs, that is going to cause the increase iron level, that is the hemosidrosis. Now the free iron which is available and not bound to the transfer is free to free to go into different parts of the body, and it's going to attach into the different body organs like the spleen, like the liver, and the hemosiderin the pigments are to be installed histologically. They have been seen as the golden brown granules, and which is being primarily seen into the spleen and liver. And now giving some more information. And when we are talking about histology, so this one particular stain we call as the Prussian blue reaction, right? Which is stain being used for coloring this hemosiderin. In that case, it is positive for this for this hemosiderin pigment, right? And the total body iron can increase up to the 25 to 30 or 25 to 30 gram or maybe more. Now coming to the copper, which is also having the very much importance while we are talking about the absorption of the iron. Now how it happens we'll see into the next slides. So copper is present into the most tissues such as the liver, muscle, bone, etc. And the liver is the storage site of the copper, and milk is to be considered very poor content of the copper. Now, the copper containing enzymes to be seen as or enumerated as the celluloplasmin, cytochrome oxidase, cytochrome C, tyrosinase, etc. The copper containing non-enzyme protein, enzyme ultimately proteins, right? So, the copper containing non-enzymatic proteins are hepatocyprin, as you see the name, hepatocyprin in liver, cuprothionin in liver, cerebrocyprin in brain, chemocyprin in RBC, and erythrocyprin in bone marrow. And the copper requirement of an adult is about 1.5 to 3 milligram per day, and excretion is mainly through the bile, and urine does not contain the copper under the normal circumstances. Means that if you need to test the urine of patient, if it is normal, it should not be, it should contain zero or the nil of the copper levels, right? And the copper is presented to the plasma tightly bound to a globulin fraction forming the celluloplasmin. Now, this how the celluloplasmin is the one which is going to help in the absorption of the iron. So, function of copper chemopoiesis, it means the copper helps the absorption of the iron from the intestine, and also it helps the mobilization of iron from its stores. Copper is an essential component of cytochrome oxidase and superoxide dismutase. Right? These are the enzymes. These are the functionally proteins which are important for the various functions, and it is also important for the formation of the myelin sheath. Um, Hemocyanin is also a cuproprotein which functions as an oxygen carrier in the blood of some invertebrates instead of hemoglobin. That means that in humans, the vertebrates, we have the hemoglobin for the transferring of the oxygen, but in case of invertebrates, it is the hemocyanin which is going to play a major role for the transfer of oxygen. Now, the vitamin C is also, for this hydroxylations requiring the copper as the cofactor. So it is also important for the muscles. Now you see that how this cellular plasmin promotes the oxidation of ferrous ion to the ferric form, and which is thus being incorporated into the transferrin. हमने पढ़ा था कि in the lumen ferric to ferrous, and when it enters that ferrous converts back to the ferric, and two molecules of ferric combine with one molecule of the transferrin for its transfer, right? And this is this ceruloplasmin is the one which is helping in the incorporation of iron to the transferrin, thus helping into the transfer of the iron to the different parts or its biological function, and it also reduces the free form of iron, which is dangerous, right? So now there's a one disease, one genetic disease we call as the Wilson's disease, where in that case the basic defect is a gene encoding a proper binding ATPase into the cell. As you can see to the one bracket being labeled liver, where this with the help of ATPase, this copper goes out and forming the ceruloplasmin. But when the defective excretion of copper takes place, it leads to the ceruloplasmin deficiency. That is causing the Wilson's disease, right? So the basic defect in Wilson's disease is the gene encoding the copper binding ATPase in the cell, which is required for the normal excretion of copper from the liver cells, right? So, in case of Wilson's disease, the copper is not eliminated, and it accumulates. So, it में क्या हुआ कि copper accumulate होगा liver में, तो वो भी एक life threatening condition बन गई, right? And also, it also affecting the oxidation of ferrous iron to the ferric, thus also releasing the free form of iron into the blood, and uh, right, and it is also it is not helping the binding of iron, uh, sorry, the ferric to the transfer, right? So symptoms, as it's being a genetic disease, so symptoms are typically seen between the teenage up to the 20s, 20s of age, and it includes the swelling, fatigue, the abdominal pain, um, the malnourishment, and poorly controlled the movements. And the treatment often, that includes the medication uh, that can prompt the release of copper to the bloodstream. Ultimately, क्या है, तो copper बाहर नहीं जा पा रहा, so it's being accumulated into the liver. So आपका काम क्या रहेगा as a doctor? We need to release the copper from the liver to the blood so that it can be treated. So once in the bloodstream, it can be eliminated from the body through the kidneys. So this is how this Wilson's uh, hepatolenticular degeneration is going to also affect the liver cell, and also is going to affect the absorption of the iron. Now the copper can cause the disease like in the aceruloplasminemia, where iron is not utilized and it accumulates into the brain and liver and causing the neural disorders. The second is microcytic normochromic anemia, where the copper deficiency affects the iron transport and hemoglobin synthesis. Uh, the third is the cardiovascular disease. The third is the cardiovascular diseases, where the copper is a constituent of the lysyl oxidase, and which makes the cross linkage in an elastin, and copper deficiency can cause the weakening of walls of major blood vessels. Also, in case of Menkes kinky hair syndrome, which is an X-linked defect, and it affects only the male children, the dietary copper is absorbed from the GI tract but cannot be transported to the blood due to the absence of intracellular copper binding ATP. So you can see that how much the copper is being important. Uh, Now coming to the second last mineral, that is the iodine. So the body total iodine is about 15 to 20 milligram, and iodine हम सबको पता है, हम लोग again we have been taught and we have read through our schooling time that the iodine is being important, and it is being important to maintain the thyroid functioning and the thyroid hormones, and the thyroid hormones being considered very important for the various metabolic functions of the body, various various body functions, and uh, uh, it is essential for the formation of the thyroid hormones. right? And the sources which are being available again, the sea, if you see, the seafood, the seafood is being considered very important. The seafood is being considered very important, like the vegetables, the fruits from the seaboard. They also, very the rich source of the iodine. And what happened in case of iodine deficiency? They boiled up. And the one of the very oldest and cheapest program of the government of India is the fortification of food is the iodine. We all eat the iodized salt, which is being available everywhere, and that too with a minimal cost, so everybody can have it. And it is also being required for the various metabolic functions, right? Now this is just to show that how this uh, this iodide when it is being absorbed from the GI tract to the plasma, and this thyroid it being sent to the thyroid, where with the help of oxidative enzymes and in the presence of TSH, it forms the thyroid, that is the thyroid iodine, right? And thus forming the thyroglobulin, which is storage form, and it forms the mono and diiodotyrosine. When the coupling of this mono and diiodotyrosine takes place, it forms the either the triiodothyronine, that is the T3, or the thyroxine, that is the T4. Now the T3, as we all know, that is triiodothyronine, is the active form of this thyroid hormone, that is, which is responsible for its major actions, right? And also further, if you can see with the help of protease, this when when one molecule of this mono iodotyrosine being breakdown takes place from the thyroxine, so it forms the triiodothyronine. So thyroxine is the storage form, whereas the T3 is the active form of the thyroid hormones, and it acts through its various actions and through its various receptors, thus performing the various important biological functions. Uh, Now coming to the fluoride. Uh, Fluoride is again as a part of dental. Yes, it is very important. So fluoride is present into the many tissues such as the bones, teeth, thyroid gland, and the skin, and it is also to known to prevent the caries. Caries is, if you see, it is a Latin term which means the decay, right? And the safe limit of intake of fluorine is being measured as the ppm, that is per part per million, right? So the safe limit of fluorine in the drinking water is 1 to 1.5 ppm, that is the part per million. So 1 ppm is equal to 1 milligram per 1000 ml, right? So uh, this is about the ppm in which we measure the fluoride. And um, it also, it is having its important biological functions when we are talking about the teeth. So it increase the resistance of teeth to dental caries, and it causes the formation of the fluoroepatite in teeth. Further, it also inhibits the fermentation of carbohydrates by the old bacteria. Why? Because the fluoride inhibits the enolase enzyme. So if you see, the enolase is one which is important for the fermentation of the carbohydrates, and the fermentation of carbohydrates, or we say unhygienic condition of the teeth or the mouth, is one which is responsible for causing the caries. This protein right? And the excess fluoride, which is more than which can be even more than 2 ppm, can cause chronic intestinal upset, gastroenteritis, loss of appetite, and the loss of Wait, more than 5 ppm can cause the mottling of enamel, stratification, and the discoloration of the teeth. Right now, fluoride levels more than 20 ppm, that means per part million. If you see, the normal level is 1 to 1.5 ppm, that is part per million. When the level exceeds the 20 ppm, it is very much toxic, and it is called fluorosis. So, fluorosis being seen as the alternate areas of the osteoporosis and osteosclerosis with the brittle bones. And the blood concentration of fluoride increases to the 50 microgram per 100 ml. Normally, to be considered as a normal, this will be 4 microgram per 100, right? And you know, the fluoride, this fluorosis is being seen and seen it spread to in more than 15 states of India, and mostly to the rural areas, right? Because generally they people drink the groundwater, right? And Genu Velgam is being seen as the characteristic feature of the fluorosis. And uh, uh, if you're talking about the sources, so the seed, fish, cheese, tea, and jowar are the rich sources. And uh, in case of a genuine welcome, the teeth becomes brittle and mottled with the whitish patches, and the bone becomes denser with the calcification at the point of insertion of muscles. So the chloride is also a very very important mineral, which is in its minimal quantities, in its optimal quantities, is required for carrying out the various important functions uh, in the teeth, right? Maintaining the fluoroappetite or inhibiting the immunology enzymes as inhibiting the fermentation. But when the level exceeds, firstly, it may affect the gastro GI system, and if increases more, then it can cause the discoloration of teeth. But when it reaches the toxic level, it can cause the deposition of the chloride into the bones, can cause the osteoporosis and the brittle bones, right? So this is all about the minerals, and I'm very hopeful that I was able to stimulate